Welcome. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at www.nhadaca.org. After completing this webinar, please upload and complete the quiz if you're interested in receiving a certificate. You can find the quiz in the file pod throughout this presentation on our website at http://nhadaca.org, or you can email traininginstitute@nhadaca.org. You can email, mail, or fax the completed quiz. Contact information is on the quiz itself. If you are a member of NHADACA and NADAC, the certificate for this webinar is free. If you aren't a member, the fee is $15. You'll receive a certificate worth 1 CE once you have completed and passed the quiz and paid for the webinar, if applicable. Through the New Hampshire Training Institute on Addictive Disorders, this one-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Drug Use Professionals, as well as NBCC, ACEP number 6754. If you have any trouble viewing this webinar, audio problems, or have any technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to traininginstitute@nhadaca.org. You can find and upload these instruction slides in the file pod to the right of your screen. This is Opioid Addiction and Treatment, Understanding the Disorder, Treatment, and Protocol, a training for multidisciplinary addiction professionals. My name is Mike Gaudette, and I welcome you to the webinar. I think most of us are aware that there's a very serious opioid epidemic throughout the United States, and particularly in the northeastern section of the United States. My hope, as a result of this webinar, is that you'll be able to state facts regarding the scope of the problem, not only in the United States, but also in New Hampshire, that you'll have a better understanding and be able to state facts regarding the history of opioid treatment in the United States, that you will state facts regarding the changes in the laws regarding treatment of opioid addiction and the implications for the treatment system, as well as the types of medications used to treat opioid use disorder. It's hoped that as a result of obtaining these objectives, that you will better be able to serve the opioid-dependent and abusing population in New Hampshire. So starting with prevalence, the latest statistics suggest that upwards of 78 people a day are dying of drug overdose, specifically opioid overdose, in the United States. Of the 21.5 million Americans 12 years of age or older that had a substance use disorder in 2014, 1.9 million had a substance use disorder involving prescription pain relievers, and 586,000 had a substance use disorder involving heroin. The 2014 statistics worldwide suggest that between 26.4 and 36 million people are abusing opioids, with 2.1 million prescription abusers in the United States and around 460 to 500,000 heroin addicts. Unintentional overdose deaths have quadrupled since 1999. So you can see by this particular graph that there has been an increase in drug overdose deaths and drug overdose deaths involving opioids in the United States between 2000 and 2014. 4 in 5 new heroin users started out by misusing prescription painkillers. As a consequence, heroin overdose deaths nearly quadrupled in the 13-year period from 2000 to 2013. That showed an average increase of 6% per year, followed by a larger increase of 37% between 2010 and 2013. So it really has taken off in serious amounts. 94% of respondents in the 2014 survey of people in treatment said that they chose to use heroin because prescription opioids were far more expensive and more difficult to obtain. Adolescents between the ages of 12 and 17 in 2014, roughly 467,000 of them were current non-medical users of pain relievers, with 168,000 having an addiction. In 2014, an estimated 28,000 adolescents had used heroin in the past year, and an estimated 16,000 were current heroin users. Additionally, 18,000 adolescents had a heroin use disorder in 2014. Women are more likely to have chronic pain and be prescribed prescription pain relievers and be given higher doses and to use them for longer periods of time. 48,000 women died of prescription pain reliever overdoses between 1999 and 2010. Prescription pain reliever overdose deaths among women increased more than 400% from 1999 to 2010, compared to 237% among men. Heroin overdose among women have tripled in the last few years, from 2010 through 2013, with female heroin overdoses having increased from 0.4 to 1.2 per 100,000 people. Today's average first-time heroin user is no longer the 16-year-old male of color as it was in the 60s. It's more likely to be a 23-year-old white woman. White women among heroin users increased from 20% in the 50s to approximately 52% in 2014. White men and women have embraced prescription pills and then turn to heroin when the source runs out. 90% of people who started using heroin in the past decade are white, and most of them in their late 20s. Heroin use increased significantly in suburbia. The one fact here that really is mind-opening and something that we should really look at is, on any given day, there are upwards of 6,000 people who are using heroin or opioids for the first time. 6,000 people a day. Among young adults ages 18 to 25, males are more likely to use non-prescription pain relievers, and among youth age 12 to 17, females are more likely to use non-medically. So we've got a picture now of some of the demographics that indicate high risk. In this particular slide, we're looking specifically at the United States, then the Northeast, and then in the first column is New Hampshire. So if you go down, it's current alcohol use, current binge drinking, current smoking, current marijuana use, alcohol dependence. That next one, non-medical pain relievers in the past year. This looks at the non-medical use of pain prescriptions, pain relieving medication. 9.76% of people between 18 and 25 years old were using pain relieving medication in a non-medical manner in New Hampshire, 9.76, versus 7.84% in the Northeast and 8.3% across all of the United States. So in New Hampshire, there appears to be a greater percentage of people between 18 and 25 years old who are using prescription medication for non-medical reasons. Equally true, looking at current illicit drug use, and this looks more specifically at opioids, 11.4% in that 18 to 25-year-old group were abusing them in New Hampshire versus 6.5% in all of New England and 6.0% in the United States. So you can see that New Hampshire is a state that is at particular risk with regard to opioid use and abuse and overdose. This is a graph. This is a graph that looks at it from a different perspective. Again, you can see that New Hampshire, which is the darker color, has the greater issue, the greater concern in each of these areas. Drug overdose deaths in New Hampshire. Again, it's something that tends to be greater in New Hampshire. Total deaths caused by opiates or opioids in 2014, 294. In 2015, 397. That's an increase of 35%. So these statistics are showing us that the issue is getting worse as time goes on. And again, here is a comparison of people in New Hampshire and in the United States and looking at drug deaths by age and gender. The number of incidences of naloxone administration by emergency medical providers, emergency medical professionals, had increased by 41.8% from 2014 to 2015. And recent articles indicate in 2016 that an additional 35% increase has been identified. In terms of the drug use by county in New Hampshire, you can see that there are particularly high use in Hillsborough County, also in the counties that I can't read them, but they're the third from the end and the second from the end. Hopefully you'll be able to read them in your when you download the screens. The treatment of opioid use disorder and opioid dependence has became a profession and started back in the 60s when in New York City there was a large number of individuals who were dying from heroin overdose. Two doctors, Drs. Dole and Niswander, were aware that there were studies done in the 40s in Tennessee that looked at how the use of methadone could help people coming back from the war, how it could help them to withdraw or to detox off of illicit substances. And they wondered if it would also be helpful and effective to put people on a dose of methadone and hold them at a dose once they are achieve what's called stabilization, and I'll talk about that in a second, but to be stabilized and hold them at that dose, and rather than to detox them off the methadone, but to have them stay at that dose over time so that they can become productive members of society. Through their work, methadone became an approved medication in 1964 in order to use in the treatment of opioid use disorder. In 1974, the Narcotic Treatment Act came into being, which limits methadone treatment to specifically licensed opioid treatment programs, methadone programs. That doesn't mean that a doctor in a general practice cannot prescribe methadone. It means that he or she, in private practice or in general practice, can prescribe it for reasons other than opioid use disorder, for pain relieving properties. But if a person has an addiction to opioids and they wish to receive medication in the form of methadone, in the United States, they have to go to a methadone program in order to be prescribed that medication. In 1984, naltrexone is approved, and it's continued at this point to be rarely used for a number of reasons that we'll get into in a bit. In 1993, LAM, or levoalpha-acetomethanol, was approved for non-pregnant patients only, but that too was underutilized in the beginning. It's very similar to methadone in terms of its pharmacology. It just has a longer half-life. So people who were on methadone, for example, if they decided to move over to LAM, they wouldn't have to go to a clinic every day of their lives. They could just go every other day, and that medication would hold over longer than the methadone did. In 2000, the Drug Addiction Treatment Act of 2000, or DATA 2000, came into being, which expanded the clinical context of medication-assisted opioid treatment. This opened up a whole new avenue for people to receive treatment, because the only approach that people had if they wished to have medication for treatment was to go to a methadone clinic. And there's a lot of resistance to do that because it's highly regulated. It demands a lot of people, especially in the beginning, where they have to go to the pharmacy every day, if you will, to get their medication. This allowed people to start to go to their own office, or OBOTs, office-based opioid treatment providers, as long as the physician, the prescriber, has qualified to prescribe the medication. And the medication in question here is buprenorphine. And buprenorphine was available in its two forms, Suboxone and Subutex. We'll talk a little bit more of that as we move forward. In order for a physician to be qualified, he or she must first be licensed to practice in their state, have the capacity to refer patients for counseling, have a limited number of patients in the beginning to 30 for the first year. Then they would apply to DEA for an additional waiver to prescribe up to 100 people. As of August of 2016, that maximum of 100 has been increased to a maximum of 275 if the prescriber meets certain relatively easy conditions, like they have continued to prescribe during that time period for at least a year. Within the next 18 months, there is movement toward approving nurse practitioners and physician's assistants to also prescribe buprenorphine in its various forms. Right now, it is restricted to physicians and DOs, but at some point, nurse practitioners and physician's assistants will be able to do the same. In order to be qualified, they have to be to provide buprenorphine and receive a license waiver. The qualifications require that they are certified in addiction medicine or certified in addiction psychiatry, or they could have served as an investigator in a buprenorphine clinical trial, or they could have completed 8 hours of training that's available to them online or through live trainings, or any other training that their state medical licensing board deems appropriate, as well as any other criteria established through regulation by Health and Human Services. So they don't have to meet all of these requirements, they just have to meet one of them. and they would be qualified to apply for the waiver. So here's a question for you to consider. The Drug Addiction Treatment Act, or DADA of 2000, opened the door to the establishment of office-based opioid treatment services. Is that true or false? Give you a second to think that through. And of course, the answer to that is true. In October of 2002, the tablet formulations of buprenorphine, Subutex, and buprenorphine naloxone, Suboxone, were approved by the Federal Food and Drug Administration. The product was launched in the United States in March of 2003. In 2004, the sale and distribution of LAM is discontinued. What they found is that there was a small percentage of people who had experienced cardiac irregularities. And since LAM was similar enough to methadone and had the same sort of function and provide the same service as methadone, rather than deal with the potential cardiac issue, they just did away with it. In October of 2010, Vivitrol is approved for the treatment of opioid use disorder. Vivitrol is the injection form of naltrexone. So let's look then a little bit at pharmacology, what medication-assisted treatment is, and the role of the multidisciplinary team in treatment. Opioids attach to specific receptors in the brain called mu receptors. There are a number of different receptors in our brain, and there are actually 3 that are sensitive to opioids: the mu, the delta, and the kappa, with the mu being the primary receptor. Think of a receptor as a cup, and the molecule coming in, the opioid molecule, comes in and fills the cup. It goes into the cup. When a receptor receives an opioid molecule, it activates the receptor and causes a pleasure response. When the opioid receptors are, like the mu receptor, when they are activated, people immediately feel pleasure. They might feel a warm sensation. They feel, over time, they begin to feel relaxed. They begin to feel worry-free, etc. And many of them describe it as a very pleasurable experience, a very pleasant one. With repeated stimulation of these receptors, tolerance is developed, which requires more of the drug in order to get the desired effect. Tolerance to opioids is a little bit different from, well, actually significantly different from tolerance to alcohol and benzodiazepines. We know with alcohol, for example, that if a person is moving along the continuum of addiction, they go through a period of time in which the tolerance for alcohol increases, so that perhaps they got a buzz at 2 drinks, now it takes a 6-pack, for example, to get that same desired effect. Over time, however, that tolerance to alcohol will begin to decrease, so that they can no longer handle that case of beer a day. Now they can only take a beer or 2, and they get intoxicated. It's different with opioids in that when tolerance occurs, people can continue to increase the amount of opioids that they're taking into their system to get the desired effect. They don't reach a point at which, like alcohol, it begins to decrease. When opiate receptors are activated, they reduce the perception of pain and produce that sense of well-being. They can cause drowsiness, mental confusion, nausea, and constipation. And this is something that is really, really important. With repeated illicit use, the production of endogenous opioids is inhibited and it atrophies. We have naturally in our bodies a chemical that helps us to fight pain, and it helps us to calm down and relax and to feel to have a sense of well-being. Those are called endorphins. When we take opiates from the outside, when we take them exogenously and introduce them to our bodies, our brains learn very quickly that that it doesn't have to release those endorphins in order to take care of any pain or any stress or anything for which it normally would have reduced endorphins. And over time, when you don't use something, you lose something. The ability or the capacity for our brains to release those endorphins decreases and then eventually can die off, can atrophy. With repeated use, tolerance sets in, which results in need for more of the drug. Some deaths due to lapse and relapse are related to the tolerance issue. The user's tolerance decreased during recovery. So that sounds like I'm contradicting myself, but I'm not. When a person goes into recovery, over a period of time, their tolerance for that drug that they're no longer using actually decreases a bit. And should they lapse or have a relapse, if they take the same amount that they used to take, they can overdose. So there are different approaches to the treatment of opioid use disorder. Not everybody needs to be prescribed a medication to help them recover. And that's really important to know and to understand. Nobody is trying to push people to go in any one direction. The important thing is, what does that person need, and what does that person understand to be the choices available to him or her? There are approaches that do not use medication that are successful for many people. For example, the use of evidence-based treatment modalities such as cognitive behavioral therapy and motivational enhancement therapy. These have been found to be very helpful for people, for many people with an opioid use disorder, in order so that they could achieve some recovery and move forward in a sober manner. There are certain things that you need to teach them about being sober that's important it would enhance their potential for success. For example, to ensure that they have a good understanding of what the withdrawal symptoms are. Withdrawal from opiates can be very painful. The people liken it to the flu times 10. They get cramps, they get muscle spasms, they get nausea, they get, there's a whole list of experiences, physical experiences, that make the withdrawal process particularly difficult. And it can last for a good 2 weeks. And then those are the acute symptoms. Then there are protracted symptoms that can go on for a much longer period of time. So we need to ensure that they know what those symptoms are. There might be some medication that they can use to lessen the severity of those symptoms, such as clonidine, if they so choose. But if they choose not to, they should at least know how difficult it can be, and to ensure that they get the support needed to get through that process. And then help them to learn, help them to give them opportunity to demonstrate that they have the skills that will help them to cope with cravings. Cravings can go on for a long time after the last use. There are essentially 3 parts to a craving. The first is the frequency, how often it will happen. Then there's the duration, how long that craving will last. And then there's the intensity, how strong the craving is. Over time, the frequency and the duration of the craving will decrease. That's a good thing. The exception to that is the intensity. The intensity of the craving often stays as strong as it was in the beginning. And so you want to make sure that people learn coping skills that get them through that intensity. It's also helpful for them to identify contributing factors to their use and potential contributors to relapse. And this looks specifically at the people, places, and things in their lives that can trigger a craving, or that can encourage or open the door to illicit use. There are certain people that they may not want to include in their lives as they move forward in their recovery, and they've got to deal with that. I mean, for some people, that feels like a betrayal. For others, it could be a family member that they need to avoid. That's not an easy decision to make. Equally true, they might be living in an environment where drug use is all around them. If they have the means by which to move, that's a good thing, but that doesn't mean that they're necessarily going to move into a better area. They need to learn how to cope with these potential contributing factors. Certainly there's a need to establish a healthy, sober support system, and this doesn't necessarily mean family. Sometimes they are getting high with their family. So you want to be sure that they are gravitating toward people who get the addiction process, who aren't going to shame them to stay sober or blame them for the things that they may have done while they were using, but who will encourage and embrace their recovery in a very positive way. Particularly helpful are self-help groups. AA or NA are not the only answers. There are others, especially if the recovering person has any concern about the spirituality piece. There are places where they can get support on the outside from their peers from a different perspective. They should also be introduced to physical and mental activities that will help to stimulate the endorphin release process. Remember, I said earlier that with repeated use over time, the body's ability to release those endogenous endorphins will be inhibited and will atrophy. Some people are able to kickstart that process back into motion. Often it takes, for example, going for runs or doing things that will enhance the feeling of excitement. So you want to work with your client to identify what those things are that would be exciting for them to do. That maybe it would involve a large amount of physical activity, for example, that can help kickstart the production and release of endorphins. But that's just a real quick list of things you want to ensure that you're working on with that person in order to enhance their recovery without the use of medication. I would also add to that list using, in a sensitive and caring manner, the toxicological screening. Very important, because we know that addiction is a disease of denial. We know that people can use and not own up to it. So you want to be able to monitor their progress through the use of toxicological screens. There are currently 3 medications that are approved should a person choose to go the route of medication-assisted treatment. When you meet with a client, don't assume that they necessarily want to approach recovery without medication. And do give them as much information as you can about recovery without medication, and then the 3 different medications that are currently approved so that they can make a wise, informed decision. Keep in mind that the longer that a person has been using, the more that they've been using, the greater the potential for the need of medication to assist in recovery. And if you have any reservations about it, if you have some biases about the use of medication, first and foremost, check yourself at the door. You don't bring those biases in, because your bias doesn't have to become the client's bias. But also, do some reading, do some thinking through about this. Meet up with some of your colleagues who work at these centers where medications are prescribed, so that you get a better sense of them. Because often our opinions about them are based on hearsay and not necessarily what we have studied and what we have directly learned. So the first medication is the one that's been around the longest, and that's methadone. Methadone is an agonist medication. That means it fully activates that mu receptor. What the studies have found over time, longitudinally, is that there is no, when taken as prescribed, there is no euphoric or analgesic effect that comes from the use of methadone. They're not getting high, and it's also not fully taking away any pain that they may have. That doses between 80 and 120 held at level to block their euphoric and tranquilizing effects. On average, 80 to 120 milligrams is about what people need. However, keep in mind, the longer that a person has been using and the more that they've been using, the higher the milligrams. And it's not unusual to see people at 200, 250 milligrams, and even higher than that. Don't let the number of milligrams scare you. They're going to be prescribed what they need in order to achieve what's called a stable state. A stable state means they're not experiencing cravings and they're not experiencing withdrawal symptoms. When taken as prescribed, there has been no change in tolerance level over time. As like we talked about with the illicit use, they get tolerant and they need more to get the desired effect. If they are at a stabilizing dose of methadone and they are becoming productive members of society, that stabilizing dose should be sufficient unless certain things occur. A sharp increase in stress, for example, or she becomes pregnant. That's another example. They also found that methadone only needed to be taken once a day. It had a half-life of 24 to 36 hours. Therefore, it was still effective 24 hours later. Unlike heroin, for example, that has a half-life of about 6 hours, so that most people went looking for the next fix about 3 hours after they had taken that fix. With methadone, it stabilizes them for the full 24 hours. They're not seeking more methadone if they are taking it as prescribed and are in recovery. It relieves the cravings attributed to relapse, and it's medically safe and non-toxic. It's not damaging them, and it's not causing any further harm to their bodies. All the studies over time have supported this. The proper dose, as I mentioned, lasts roughly 24 to 36 hours. You don't get euphoric, you don't get sedated, you don't get pain relief. How long a person stays on medication depends upon the person, and that's really, really important. You would no more say to a person on methadone, when are you going to get off it? You need to get off that stuff, than you would a person who's on insulin for another medical issue, diabetes. If you truly understand and accept that opioid use disorder is an addiction, which is a disease, then Don't fight the use of medication to treat a disease. It's scientifically proven to be effective. So how long they're on that medication, it's up to them. That doesn't mean that the prescriber doesn't talk to them about whether they want to stay on it or not. Absolutely that happens. Because people always need to know that there are choices in front of them. That's very empowering to have choices. This is probably the biggest thing that I want you to take with you around about methadone. The most significant long-term effect on a person's health is marked improvement. All the resistance toward the use of methadone in the treatment of opioid use disorder is based on hearsay, and it's also based on the war stories that come out of clinic life years back. Today, when it is done according to regulation and using best practice principles, people get their lives together. They become productive members of society. They're not robbing and stealing and killing and burglaring and all that can go into that. They're not. They are becoming gainfully employed and able to develop healthier relationships with people. Most significant long-term effect, and this has proven itself true longitudinally in a number of studies, most significant long-term effects on health is marked improvement. Any side effects that come from methadone, it could be somnolence, that nodding behavior, or they could have some difficulty sleeping, etc. The side effects usually subside within a month, just like most other medications. Once you get used to the medication, the side effects will go away. So this graph just quickly shows you the difference between an illicit drug, and in this case heroin, and the use of methadone. With heroin, the black line, almost instantaneously upon taking it, usually smoking or injecting or snorting, they'll get that high feeling. And then within a very short period of time, usually around 3 hours, they're beginning to move from what feels normal to them into this subjective sick portion, where they then go into full-blown withdrawal. So the entire yellow square represents a 24-hour period, and you can see where with the black line with heroin use, for example, they quickly, within 3 to 4 hours, begin to get into that subjective sick period. Whereas the white line is methadone. When taken as prescribed, they don't get sick and they don't get high. They stay essentially in the normal range. Once they have achieved that stable state, they take it as prescribed, they're able to become productive members of society. The next medication to have been approved is buprenorphine. Now, buprenorphine isn't a new medication, and it is something that has been used for many years in Europe when treating opioid-dependent persons. It's a partial agonist opioid, which means that it only partially activates the receptor, whereas with methadone fully activates the receptor. And then it also acts as a blocker, which we'll get into in a second. It also produces a ceiling effect at higher doses. You can only prescribe so much buprenorphine, after which it becomes ineffective. And that cap is 32 milligrams. If a person cannot be stabilized at 32 milligrams of buprenorphine, then certainly buprenorphine is not the medication of choice for them. Most people are stabilized at 16 milligrams. And in fact, roughly 90% of the people who are prescribed buprenorphine will be on 16 milligrams or less. There are some who get 24. There are some at 32. They're not as that's not as often. But if you have to go higher, then certainly buprenorphine is not the medication for you. Probably need methadone. It has the effects of opioid agonists, as I mentioned, although it's limited. So that's what the partial agonist piece of it is. It binds strongly to the opioid receptor, and it's long-acting. It's safe and effective for therapy, excuse me, for opioid maintenance and for detox. In other words, people can be maintained on buprenorphine for long periods of time, just as with methadone, or they can use it as a detox medication, such as what is done with methadone as well, to get off the illicit substance and to attempt to continue in their recovery without the use of medication. People have the right of choice, and as long as they understand what those choices are and can make a wise, informed decision, our job is to support them in that. It's a synthetic opioid. It has, because it's a partial agonist, it has the characteristics of both an agonist and an antagonist medication. Agonist medication, such as methadone, or an agonist drug, such as heroin, attaches to the opioid receptors in the brain, the mu receptor, and it fully activates the receptor, causing pain relief, analgesia, causing some pleasurable experience, some well-being, etc. The antagonist effect is then to block the receptor from getting any more of the opiates into their body. So what buprenorphine does is it goes into the person's system, into their brain. If the opiate receptors are empty, it will go in and partially activate it, but then it will cause a cover, if you will, to that receptor so that no additional opioids can go in there and can activate the receptor. That's what the antagonist properties do. Buprenorphine has been found to be as effective as moderate doses of methadone. So currently the literature says if you can be stabilized at 60 milligrams of methadone, you're probably a good candidate for buprenorphine. There are studies going on around the country looking at just that. And can people at higher doses also switch over to buprenorphine should they choose to do so and still have effective? Keep in mind that buprenorphine has a ceiling effect, so you can only prescribe so much, and therefore was their use such, and they're such that they need more than what the buprenorphine can give them. That's why they're looking. That's why right now it's 60 milligrams of methadone. If they can be stabilized at that, then there hasn't been too much damage, and the buprenorphine can be effective. Whereas they're looking at whether that can be increased to 120 milligrams. It's also as effective as moderate doses of LAM, which makes sense because LAM is very similar to methadone in terms of what it does. The partial agonist effects makes it mildly reinforcing. That encourages people, that's especially in the beginning when they're getting that medication, there's a mild reinforcement, a little bit of a well-being feeling that after they take it, and that helps them to continue coming back. After a year of buprenorphine plus counseling, 75% of patients stayed in treatment compared to 0% who were on a placebo. If that doesn't speak to the effectiveness and the efficacy of this medication, then nothing will. I mean, this is evidence, evidence that the medication works. And that's really important to remember. It's evidence-based practice. Vivitrol is the injectable form of naltrexone. It is an antagonist medication, and it was approved for the use in treatment for opioid use disorder as of October 12th of 2010. 36% of those who had been prescribed and injected with Vivitrol were still in treatment at the end of a 6-month study, compared to only 23% who were on a placebo. So even though, with buprenorphine we said 75% compared to 0, and now we're saying 36% compared to 23. Even though that seems slight, for those 36%, that's a big deal. Essentially, because it's an agonist medication, it sits on the receptor, the opiate receptor, and acts as a blocker. It won't allow any agonist or partial agonist to go into the receptor and to activate it. That's essentially what the Vivitrol does. Unlike methadone and buprenorphine, it's administered via intramuscular injection. People get an injection in their gluteus maximus. They only have to get that injection once every 30 days. And it can be prescribed by a nurse practitioner or a physician's assistant, unlike buprenorphine, which currently has to be prescribed by a physician. There are few to no side effects that will occur when administered 7 to 10 days after the last use of an opioid. And this is really important to understand and for clients to fully understand. In order to be prescribed and administered the Vivitrol, they have to go through a 7 to 10 day period where they are abstaining from opioids. And the reason for that is, if they were to have an opioid in their system at the time at which they received the injection, it would cause them to get sick. They would go into withdrawal and they would get sick. Whereas if they wait that 7 to 10 days, the opioid is going to be out of their system, and then it will act as a blocker and they won't get sick. So if they're switching from methadone or buprenorphine to Vivitrol, they've got to have that 7 to 10 day abstinence in order to get their first dose. And as I said, if the opioids are present when the injection occurs, they're going to be put into withdrawal, and there's nothing you can do about it because you just gave it to them intramuscularly. There's no way of taking that out. All of the following are true about methadone except which? It's medically safe and non-toxic. The proper dose lasts between 24 and 36 hours. It is not recommended for pregnant women. And it relieves cravings that often lead to relapse. Which of A through D, which is not true? I'll give you a second to identify it. And the answer is C. Methadone is not, yes, methadone is recommended to use with pregnant women. It's not FDA approved, but it is the medication of choice. Now, people can be prescribed Suboxone or Subutex. They need to sign a waiver saying that they understand that methadone is right now the medication of choice, that Subutex is still being studied as far as its effectiveness for use with pregnant women. And as long as they sign that waiver, the physician can prescribe it. Many women choose to sign the waiver because if let's say that they were on Suboxone and they get pregnant, they move to Subutex, partly because the effects of the naloxone, which is an antagonist, is not necessarily favorable to the life that's developing within them. So they move to Subutex, They sign the waiver because if they choose to go methadone, they then have to go to a methadone clinic and they have to go every day to get their medication. Whereas if they're on Subutex, it depends on how much the physician is willing to give them, they can get up to a month's prescription. So the one choice that is not true is that methadone is not recommended for pregnant women. It is recommended. With respect to Vivitrol, there are no withdrawal symptoms when a person stops taking naltrexone. Naltrexone is the pill form of Vivitrol, or Vivitrol is the injection form of naltrexone. There are no withdrawal symptoms. If a person is being maintained with naltrexone and they miss a dose, they're not going to get sick. For some people, this has created a little bit of a problem. It encourages, well, let's put it this way. I'm on naltrexone, but I hear there's a party tomorrow where there's going to be some good opiates around, and I want to get high. All I have to do is not take my naltrexone today, and by tomorrow, it'll be worked out of my system, and I can get high. So the pill form creates a little bit of a problem with respect to monitoring people's recoveries. You can't do that with Vivitrol. Once it's in that person's system, it's there. And if they try using on top of it, typically they get no results from it because it blocks the opiates from activating the receptor. Where there is a problem is that some people will take especially large amounts of opioids with the hope of being able to get high, and this can lead to overdose and death. Again, methadone is still preferred and safer medication for pregnant women. Naltrexone and Vivitrol prohibits the effectiveness of pain-relieving narcotic medications. Many of us have struggled with this whole use of medication to treat drug addiction. You're giving a drug to treat a drug. And we need to look at that because a lot of times the resistance that we have, the biases we have, are based on myths and not necessarily fact. So there are 4 that come up a lot, and I just want to go over them briefly. For starters, myth number 1 is patients are still addicted if they're on medication. The truth is, addiction has to do with pathology. Pathological use may or may not include physical dependence, but addiction always has pathology: stealing, robbing, poor relationships, poor work performance, unemployment, all different things related to the use of that substance. And maybe they're physically dependent on the drug of abuse, and maybe they're not, but they're having problems in their lives as a result of the drug use, and yet they continue to use. So addiction and physical dependence are 2 different things. Many of us have physical dependence on any number of things, but that doesn't mean that we have any pathological behaviors associated with that. We're all physically dependent on the air that we breathe, but we're not killing each other, at least not in 2016, in order to get our fix of air. It's available for us. Myth number 2, medications are simply a substitute for heroin or other opioids. And I got to tell you that our field has kind of spread that myth around, because at one point, medication-assisted treatment used to be called replacement therapy. And so here we are, we're even saying that we're replacing one thing for another. Well, that left a little bit of a bad taste, so they decided to change that word, and they did, to substitute, which I'm not quite sure what the difference is between replacing something and substituting something. But here we are with substitution therapy, and in some circles that term is still used, and it just gives an odd taste in the mouth about just using one thing in place of another. Medications are corrective, not curative. When taken as prescribed, they are safe. They allow the person to function normally, not get high, and they are legally prescribed, not illegally obtained. And that's something that I think we need to keep in mind. We're talking about medication to assist in recovery from a drug of abuse. If you can think of medication as something that you get inside of the pharmacy, and the drug of abuse is something you can buy behind the pharmacy, so to speak, keep those two words separate. We're talking about the use of medication legally to deal with an addiction to a drug, illegal use. Providing medication alone, this is another myth, is sufficient treatment for opioid addiction. Medication is absolutely important for those who need medication. It helps them to stay to maintain their recovery. But the complete treatment package has to include other elements as well, and not just meeting with a counselor once in a while. What they have found is that enhanced counseling is the most effective. And by definition, enhanced counseling means counseling at a frequency and type that is based on the medical necessity of the person we're serving. So some people come in and they need to be seen quite frequently, every week, twice a week, 3 times a week. Other people can be seen once every other week, once a month, depending upon where they are in recovery, what they have for strengths in their lives. Actually, if you look at the ASAM criteria, the lower the risk in all those different dimensions, the less need there is for more intense treatment. The most important thing is remember to keep it enhanced, that it's relevant to the medical necessity of that individual. And then, on top of all that, are the case management or care coordination issues that need to be attended to. Keep in mind, for example, that people, when they were using illicitly, may not have gotten the proper medical and dental care. So there should be some case management services that would hook them up with their own physician and some dental service so they can begin the process of taking care of their bodies. Equally true, there should be some consideration for nutritional evaluation and advice, because poor eating habits are a big part of the addiction process. And then myth number 4, patients are still getting high. I mentioned earlier that methadone is a full agonist just like heroin. So aren't they, and with Suboxone, there's a mildly pleasant feeling for the first month. So aren't they getting high? The truth is this: when taken as prescribed, after they've dealt with the initial side effects of the medication, etc., that person is going to feel normal, not high. Buprenorphine has the ceiling effect, so even the euphoria that they feel in the beginning is not as much as they did when they were using illicit substances. Methadone is highly medically monitored, and as soon as they get past any period of time with side effects, they stabilize. And with naltrexone or Vivitrol, there are no narcotic effects, so then there is no getting high. Counselors need to screen and recommend people for referral to qualified physicians. And this is true whether they're going to be on medication or not. Everybody should have a good physical evaluation, physical assessment, and a plan to deal with any physical illnesses. Physicians need to look at a number of issues when they're meeting with people. Are they currently addicted to opiates? What medication is the best medication for them? The longer they've been using, the more they've been using, and the more intense that they've been using in terms of the experience of that drug, the greater the possibility that they should be prescribed methadone to start. To at least, because buprenorphine is a partial agonist that has a ceiling effect and there's only so much that can be prescribed, often people with longer histories of use do much better on methadone. So here's a number of questions that a physician is going to be asking the client and assessing to make that determination. Counselors do not have the ability to prescribe or to say whether medication is right or not right. That is 100% the responsibility of the prescriber, and it is out of the scope of practice of the counselor. So again, here are some additional questions that the prescriber will ask. Psychiatric stability is very important. Are they psychiatrically stable enough that they would be med compliant if medication assistance is the route that they go? Or will their psychiatric symptoms interfere with their ability to be compliant? And that's very important for the prescriber to assess. Also, are they addicted to or have a high dependence on other drugs, such as buprenorphine? I'm sorry, not buprenorphine, benzodiazepines or other central nervous system depressants. The mix of benzodiazepines and some of these medications can create a problem. And in some cases, overdose can occur. So the prescriber needs to be aware of that. Then, of course, there are consultations that need to occur with regard to HIV and STDs and hepatitis or any other impaired liver functions. So I've brought you through looking at statistics, looking at real quick pharmacology, what opiates do to the system, some of the approaches that you need to be aware of if you're helping a person without the use of medication to move in recovery, and then of course the 3 different medications that are currently being prescribed. The most important thing is people are dying today, and we need to be open to whatever route of recovery is going to be most effective with the individual. I hope that this has been helpful. Please consider taking the quiz and getting the 1 hour of CE, and any feedback that you can give would be most helpful. Have a great